Today's first topic is Pathogenesis and Predictors of ROP by Dr. Meena CK. Madam is pediatric ophthalmology consultant at Madam. Surgeries will do it in the end. Madam is pediatric ophthalmology consultant at Little Flower Hospital, Angamal. Over to you, Madam.
Good morning, everyone. At the outset, I would like to thank KSOS and Dr. Sheera for this opportunity. This is purely theory, pathogenesis and predictors of retinopathy of prematurity. As all of us know, the retinal vessels develop from the optic disc by about 16 weeks of gestation, and it reaches the nasal aura by 32 weeks of gestation, and the temporal retina is vascularized by 40 weeks of gestation. When the fetus is in utero, it is in a hypoxic state. That is, the stable partial pressure of oxygen in the arterial blood is about 22 to 24 millimeters of mercury. So it is in a hypoxic state, but it has got that advantage, that is, it stimulates vascular endothelial growth factor, which in turn stimulates retinal vessel growth into the peripheral avascular retina. So when the child is born into a high oxygen atmosphere, so there's a sudden change from the hypoxic state to the hyperoxic state. And especially when the child is born premature, there is supplemental oxygen being given for the well-being of the child. That itself will increase the risk factors. So the child from the hypoxic is going into a hyperoxic state. So what happens then? So this is the phase 1 of ROP. That is the first phase. What is happening is that the retinal blood vessels are reacting to the hyperoxic state by causing vasoconstriction, and naturally there will be a down regulation of the vascular endothelial growth factor and insulin-like growth factors, and subsequent to that there will be cessation of the retinal blood vessel growth. So first there will be a cessation, that is phase 1, usually occurs in 22 to 30 weeks of post-conceptional age. Now once this vasoconstriction occurs and there is an avascular retina there. So this retina is starting to mature, and it needs oxygen, and there is no vascularization. So naturally there will be a stimulation for VEGF and insulin-like growth factors. So these factors are being produced. So when the avascular retina is minimal, then there can be only a physiological change, that is, all these VEGF will help for the vessels to grow into the periphery. But when too much of avascular retina is there, you can have abundant growth factors, and that can be dangerous, and it causes disorganized retinal vascular growth. And this occurs mainly at the avascular and vascular junction. And along with that, you can have damage to the existing vessels also. When the avascular retina is when the size of the avascular retina is more, then even the existing vessels can be affected, and this results in the aggressive retinopathy of prematurity, where there will be dilatation, tortuosity, hemorrhages, and which is the most dangerous condition that we have to treat immediately. Now coming to the predictors of retinopathy of prematurity, there are a number of predictors have been mentioned in the literature, but the predictors that we are aware of, or what the neonatologists tell us, are mainly the low birth weight and gestational age. As all of us know, as the birth weight reduces and the gestational age reduces, the risk factor is extremely high. And oxygen, as we know, is another single most important risk factor. And VEGF is the most intensely studied angiogenic factor, considered to be the central player in both physiological and pathological angiogenesis. Insulin-like growth factor, it is a non-oxygen regulated factor, and clinical studies indicated that there is an inverse relationship between IGF levels and severity of clinical ROP. And all these we know that if there is bacterial and fungal sepsis, the child is more prone for ROP, and the length of the hospital stay and longer length of initial hospital admission obviously will be associated with higher rates of ROP. Human milk has been found to have protection against ROP, And patients with low platelet count, that even we have seen, like they come with more hemorrhages, seem to have a greater risk of developing severe ROP. Now, association of erythropoietin, it has been found that exogenous erythropoietin protected the retina in phase 1, but it worsened pathological vascular growth in phase 2. And this is also an interesting thing, that high levels of neonatal HbA1c, they are a feasible biomarker for proliferative ROP, and low levels are biomarkers for non-proliferative ROP. Then comes all the experimental ones like lactate, urinary N-terminal, B-type natriuretic peptide, etc. So to summarize, hyperoxia followed by avascularity, followed by the proliferation, these are the steps that happen in the ROP pathogenesis. Thank you.
Thank you, madam, for that very informative.